Hi, good afternoon, all. Am I audible?
Yes, and you are audible.
Okay, thank you, ma'am. First of all, I would like to welcome you all for the session, and we have two more sessions. Ma'am, I'm handing over to Anusha, ma'am, to introduce our faculty. Ma'am, a warm welcome for you. Anusha, ma'am? Are you?
Yes, hello, yes.
Okay,
Good afternoon.
good afternoon, ma'am. So, today we are going to talk about pediatric palliative care. Ma'am, please introduce our faculty.
Good afternoon, everyone. This is Anusha. I'm the facilitator of today's session. So today our topic is pediatric palliative care. Our speaker, Dr. Veena Anand. She is Associate Professor of Pediatrics at SAT Hospitals, Government of Medical College. And she holds an MD in Pediatrics and MPhil in Clinical Epidemiology and a Global Fellowship in Palliative Medicine with specialized training in advanced pediatric palliative care. And also, she is a research scholar at Kerala University, PhD at Kerala University of Health Sciences, with multiple indexed publications and experience as a reviewer of Indian pediatrics and BMC pediatrics. And she is actively involved in pediatric palliative care clinics and leadership programs also, and disability management children, and integrating clinical care and teaching and research, and recognized for academic contributions including faculty roles in research methodology workshops and MBBS batch coordination, and an awarded winning paper presentation in childhood disability management. Welcome, ma'am. Welcome for this session.
Thank you for the introduction. So let me share the screen. Is the screen visible now?
Yes, ma'am.
So how many participants are there supposed to join?
Almost 50 members have
50, 50.
five,
Ah,
but most of them from Ladakh, so they are facing some issues, ma'am. So
oh, all are from outside, outside
yeah,
India.
yes, ma'am. Most of them are from Ladakh, and
Hmm.
so they are facing some network issue and also.
Okay, okay. So let me start the
Yeah,
session.
ma'am, you can start. I'll push
For the
from my side.
introduction to pediatric palliative care. How many sessions over? Yeah, what?
So,
Pardon?
so it's almost 16 sessions, ma'am. We have
Oh, okay, okay.
two more sessions. This is
Oh,
the
oh,
17th session.
okay. All are from outside India.
Participants, ma'am.
Hmm.
Not outside, ma'am. Not from in. They all are from India only,
Hmm.
but Ladakh.
Ladakh. Okay, okay. So let me start. The objectives of this session are definition and scope of pediatric palliative care, unique needs of children and families, common conditions, the multidisciplinary family-centered approach, the WHO pain ladder for children, psychosocial and spiritual support. First, I'll tell if any doubts in between, you can post your questions or your comments in the chat box so that we can discuss. So anybody caring children in their clinical practice? Now I think how many participants? Participants only 12 now, isn't it? How many are there?
15 participants are there, ma'am. Including
No,
us, 18
18.
members
Okay,
are
okay.
there.
No, anybody is caring children? If any difficulty in understanding your, please tell me. Okay, if any difficulty, the sound is not clear or some problems, please tell me. Okay, anybody caring children in their clinical practice? Among the 15 participants, please you can unmute or you can just post in the chat. Yes or no, like that, so that I can know.
Mr. Kanagaraj have deployed, yes, ma'am.
Yes, okay, okay. Kanagaraj, okay. So anybody working in palliative care, currently working?
The participants kindly respond.
Can you use the mic or you can use the chat?
No.
No one is currently. Okay. So this will start with a scenario of a 10-month-old baby. The baby is diagnosed to have an intracranial space occupying lesion, and the biopsy showed inoperable malignant brain tumor. Does this child require palliative care? Can someone post in the chat, or you can unmute and tell?
Is it right, madam?
Yes, yes. Is it who told Kanagaraj?
Yes, ma'am.
Yeah. Oh, okay, very good. That's so definitely we will think whenever there is a cancer, it is everybody will accept also. That is the thing. Okay, very good. This is another child, 12-year-old female child. It is he is bedbound. No, even now not attain head control and all. Child is having at birth itself diagnosed to have CNS malformation. Child is having hydrocephalus, ventriculoperitoneal shunt. So the diagnosis is spastic quadriplegia, seizure disorder, no recurrent aspiration. So does this child require palliative care? Any response? Yes or no?
Actually, yes, madam.
Yes. Okay, very good. So this child also require palliative care. So, but the issue is the many times when the child is having malignancy, they will be accepting it easily, isn't it? But it is having some other diseases like non-malignant condition. Even now, it is for as far as pediatric age group. Definitely for more than adults in the pediatric age group, it is their reluctance to accept that palliative care is needed because in our culture, it is thought that the children are never supposed to die. So whatever thing is there, whatever interventions are possible, we have to do. That is the attitude of our society. So it is very difficult. Now also that is one barrier for the pediatric palliative care. They won't accept they want whatever things are possible to do. So this is another scenario. 10-year-old child with the metastatic osteosarcoma femur. And child is complaining of severe pain. Already child has undergone many treatments, chemotherapy, radiotherapy, chemo, so many treatments are now at a stage, they are telling there is no curative option and may require because of this pain and all, they have advised palliative amputation. So when we see what all the things usually we will do in our conventional approach, whenever we are seeing what options we will be telling. Generally, we will be seeing children with pain and all. Complaining severe pain mean usually in conventional. Before coming to palliative, what all things we will be doing? The first thing what we will be doing? Can anyone tell? Child is complaining of severe pain. So what we will do? Whenever there is pain, what we will be doing?
Giving medication
Yeah, good. You will be
and the psychological support.
Usually in conventional approach, you will be giving only paracetamol, isn't it?
Yes, madam.
When now you are taught this palliative care, that is why you are telling this psychology, isn't it? In the conventional approach, we will be just giving paracetamol and send them back, isn't it?
Yes, madam.
Generally, that is happening, isn't it? So what is the WHO definition? We will see that is the active total care of the child's body, mind, and spirit. It also involves giving support to the family, not only the child. We have to give support to the family also. That so that we will alleviate the physical. That is a pain. We told the conventionally what we will be doing whenever see such a child, we will give paracetamol. Okay, you go. Anyway, they are advised only this no curative option already they are told. So we will go with this paracetamol for pain we are giving and nothing more to be done like that. But in the palliative approach, we have to alleviate not only the physical, the psychological, their social and spiritual suffering also you have to be taken care of. So that ultimate aim is to improve the quality of life. That is the WHO definition for the palliative care. For this pediatric also the things. So what is this total suffering? So it includes physical. First, definitely physical we will be assessing. What is the disease burden? Here, what all the problems might be the child might be having. Child might be having pain, swelling. And already child has undergone so many treatments that adverse effects of treatment itself might be different symptoms might be there. So that also we have to assess. Whatever other conditions are there, that also we have to. So all the physical things we have to evaluate. Along with that, you have to look for the psychological aspects. What are the psychological aspects a child might be having? As far as comparing to the adult population, the psychological things are we are not at all addressing, not much addressing their issues. After all, they are kids, we will be just listening to the parents. What the parents are telling that we will be taken care of. But the poor kid, that they won't, nobody will ask also what are their issues. But they are also having emotions. They will be having sadness, anxiety, depression, the fear of suffering. But they will be overhearing all those things. They will be overhearing what the doctors are or sisters are telling the parents. They will be overhearing it. But no one is directly, nobody will be taking care of their issues. Nobody will be directly asking them. So that should be avoided. We have to assess their issues. And sometimes the children might be thinking in their weird mind, they will be thinking because I haven't, I have done those things. That is why I got these issues. So like that, guilt feeling also might be there. So all these things have to be taken care of when we are addressing the symptoms in a child with serious illness or chronic illness. In spiritual or bigger children, they are also having spiritual issues. We can assess the spiritual issues. They will be having the issues with the why, the meaning of life. Might have lost faith, loss of faith in their beliefs, fear of the unknown, then concerns about death and the loved ones. What others, my parents will do if I die. What my siblings do if I die. So many concerns will be there in their mind. And also, why me? Why all these things are happening to me? Or destiny, karma, and also questioning relationship with God. All these things occurring in the adult population, all those things can occur in the pediatric population also. The social issues. Once the child is having diagnosed with some serious illness, definitely they will be viewed as someone different. All of them will be looking at them with a strange face. So they will be feeling loneliness. They won't be allowed to go to school. There will be loss of school, loss of play, loss of friends. And also many of the time the parents will be taking care of the full time. They will be sitting with them. So there will be fear of being a burden. My parents are not going to work because of my illness. So loss of independence. Everything, whatever thing I used to do alone, now I am unable to do. So those of loss of independence. I need this help or support for my even for routine activities. So all these things are leads to social issues. So in the pediatric palliative care, what all things we can do for the children? definitely we had to do the symptom assessment in detail. We had to assess what is their issues. Then we can do the management, appropriate management, and then you can, whatever issues they have, problem they have occurred, we can bringing back to their, whatever possible way we can bring them back. That is rehabilitation towards normality. Definitely we may not be able to bring them back to the absolute normal, what is in the past, but we can try to them to the what are the possible ways we can improve their capabilities. That is rehabilitation. In counseling, that is a cornerstone pillar of the pediatric palliative care or any palliative care area to communication, proper communication and the shared decision making, and be with them, the support given to them. Decision support, that is shared decision making. That to respect the cultural and spiritual values of the family. They may, the whatever culture they are belong, they have to support them. That is, most of the time the decision makers are, many times we will be counseling the parents. When they might be telling, no, we want to discuss with our grandparents also, their grandparents also. So they will be bringing them. Some uncles might be coming, some religious leaders, political leaders, so many issues. But because of the difficulty in dilemma in decision making. So we have to allow those their wishes. In the difficult situations that may be needed. So that is so what about the palliative care models? When we have to start the palliative care? Ideally, when we have to start, can anyone please tell or chat? Ideally, when we have to start the palliative care? In adults also same.
At the time of admission itself.
But good. That is at the time of diagnosis itself, we have to start the palliative care. But the children, many times, there's some chronic diseases and genetic and rare diseases, the diagnosis may go late. So there and all, the palliative care referral may be late, but you should avoid some, whenever the child is diagnosed with some complex diseases, even not waiting for the before confirming the diagnosis itself, we can start the palliative care. So the first picture shown in the rectangle, already you might have learned in the adult palliative care sessions. That is the lifelong care. Previously, the old model was like that. First, whenever the diagnosed with an illness, we will be giving the lifelong care. That is, we will be giving the. Then when at a stage when we are reaching that it is no longer helpful, that is the curative treatment is no longer helpful, then only we used to go for the palliative care. So, but the concept has changed. That is the current concept. That is a second figure. So, whenever we are thinking about palliative care, this figure should come into your mind. That is, along with the lifelong therapy, you have to start the palliative care. Once the role of the lifelong care is become lessened, this role of palliative care increase. An ultimate stage is reached when there is no longer the lifelong care is helpful. The management is futile. So at that time, we will be having only the palliative care. And when the child is actively dying, then the role of hospice care, or we don't usually have hospice. That is in our setup, it can be called as end of life care. There, whenever the child is or person is actively dying, we will be giving the end of life care. And the consult also includes the after death care also. That is a bereavement support. That is this picture. That is the current model we are following. That is starting with diagnosis, and the role of palliative care is increasing, and the end of life care, and also includes the bereavement support. That is a current concept. So even if we have to, whenever sometimes different types of diagnosis that pediatric palliative care that need is worldwide, it is around 4 million. Global, the total number of children in need of palliative care is almost 4 million. That is WHO, this assessment that shows that it is around 4 million, and only very less only. There is a huge unmet need. India also only around less than 1% only is getting the palliative care. So where we can give? So generally in India and all, this is mainly in the attached to the tertiary care facilities, but it can be conducted in community health centers. In Kerala and all, it is doing going well, the home care, wherever possible, we can do the palliative care. Broad multidisciplinary approach is needed, but in all situations, we may not be fortunate to get the whole multidisciplinary team and all. But we can, if it is there, definitely we have to make use of the available resources. And also the level of care according to the specific needs and may change over time. So in the initial stages, child may be requiring only that not much palliative care and only just basic principles. But as the child disease progresses, the child condition worsens, the different level of care may be needed. All these things we have to discuss with them, the initial stages, so that we will build a rapport with them. From the initial contact itself, we will build the trust. That is the most important thing. We have to build the trust and we have to be with them together. That is the importance of early referral to the palliative care. So unique needs of children. We can't consider the children as just a small adult. Definitely, it is all of us know that is the dose also is different. We can't just give the half the dose of the child or 1/4 dose like that. So and the drugs also might be different. Especially including the pain management, the drugs for the pain management. All those things are different. So you have to have some knowledge about how to manage the children. So because their causes of illness are different, the death will be different. And here the assessment, we all know that it is difficult to assess the symptoms of children because they will not be self-reporting. Sometimes because of fear also they may not self-report. Even if they have pain, they may not report because they fear that if they report the pain, they may be getting some injection. So like that, they may hide their symptoms. Even if they're telling that there is unavailability or there is lack of the formal assessment tools for symptoms. There else, we have so many tools and validated tools are there, but in children, it is difficult. Only very less tools and it is also not much validated, very difficult to assess the symptoms. So assessment, if it is a developmentally delayed child, it is become very much difficult to assess. We have to depend on the caregivers. What is the change in the child's behaviors? Any difference? Are you noticing any difference? So that you have to think that consider the developmental age of the child. So the physical and emotional needs will differ. So depending on the developmental age and the chronological age, all these needs will differ. So the care plans changes. And also, if you are on counseling, they may require age-appropriate counseling. We can't tell, like as if you are telling to an adult, we can't tell the children. You have to be in a different way. You have to approach them, but so that they will understand, they will trust us, so that we can manage them well. So all these things you have to keep in mind whenever we are managing, whenever we are seeing a child with chronic illness. So support, what all other than the usual support, we have to support also should include extended play. So play is a means of communication also. What from their play also we can understand what they are meaning. Also, we have to support, educational support is needed. So once there is child is diagnosed with illness, they may be facing so much problems and they may be wishing to go to school, meeting teachers, their friends. So in a child, we can to make some alternate options. We should help them with that options also. And also we have to help them to maintain the social interactions so that their illness suffering will be lessened. Also many times the siblings may get affected because of the child's illness. Everyone will be behind the child who is sick and nobody will be taking care of the sibling. Their education may get affected, their social life, all the things might be getting affected. So these are, and also they will be worried. Nobody will be telling them what is happening to the other by sibling. They will be in a dilemma. What is happening? I don't know. So that also you have to taken care of. The grandparents, there are also care made babies, other persons with illness, they may also not be getting the care. So all these things we get to taken care of. And also the management differences are there. For example, the pain and all, there is different the doses are different and the drugs are also some very differences are there. And also in India, I already told it is a belief that the children are not supposed to die. That is the concept. So in such a situation, even even when the child is actively dying, if we are counseling, the parents might be telling, no, we want to do whatever things are possible. What all things possible, we will do. Because the belief is that children are not supposed to die. So all these that can create social barriers for the pediatric palliative care. So let us see the diseases. What are the common conditions, that need palliative care? Have you seen any case? Anybody any experience with a child with chronic illness requiring palliative care? It's numerous enlisting of the diseases enlisted by WHO for the children needing the palliative care. So here the maximum is for what? Can anyone tell maximum for which condition?
HIV disease.
HIV. Then what is coming after that?
Premature birth and
Premature,
birth trauma.
very good. That prematurity and related birth trauma and other conditions. After that, it is
Congenital
congenital
malformation.
malformation. Okay, so it is malignancies and all very less only. Leukemia 1.1, malignant neoplasm 4.1 only. But these other conditions are having the. But the problem is these things they are not. Once they hear the word palliative care itself, they'll be reluctant with that service. That is a issue. So depending on the different conditions and the trajectory of the conditions, we can classify simply into 4 groups. That is, some diseases there, sudden unexpected death can occur. That is, there will be child is normal and suddenly child will get, that child was going normally. Suddenly what will happen? Child will contract some disease and child can develop. That is a sudden unexpected death. Can you tell any condition where the sudden unexpected death can occur?
Blood cancers.
Cancer. That is given here, second option. First option, can you tell any other? Child was going well, but suddenly developed acute illness and died. For road traffic accident, major accidents. Or suppose a child developed viral fever. Child was doing very well, suddenly developed viral fever, some myocarditis occurred, child died. Like that and also happen, cardiac condition. So that is an example of sudden unexpected death. Second one is death from potentially curable diseases like cancer. So here some treatment is there, but the treatment may fail. So once a child was doing like that, given the dip, we are given the chemotherapy or whatever some intervention we are done, and the child has improved somewhat. Again, what happened? And dip, some relapse occurring. Relapse occurred, and again child was succumbed to death. That is another. Some other conditions, the child from the birth itself, child is dipping. The premature baby, like anencephaly, major congenital malformation. There, what can happen? Within hours or weeks, they can succumb to death. So some other conditions, what is happening? From birth itself, child is dipping, again going to a dip. Some infection occurring, some again child is somehow coming back. Again, child, this is progressive disorders like neurodegenerative disorders, muscular dystrophy and all. What is happening? The child is not going to the normal stage. With any infection or some stress is occurring, that again child is dying. Here the problem is the parents and the children suffering as if the child is dying again and again. That is the issue. Again and again, then sometimes child may recover, but ultimately there is premature death is occurring. That is, one example is muscular dystrophy. So knowing the trajectory, we can help in the planning the care. That is the importance of knowing. So this is according to disease trajectory, the 5 conditions are told. One is the life-threatening condition where curative treatment is there but may fail. For cancer, treatment is there but it is not 100% sure. cardiomyopathies, severe trauma. Sometimes they may recover. The premature death is inevitable and intensive treatment can prolong life. That is cystic fibrosis and all. Treatment is there, but anyway, child ultimately there is premature death. Then progressive condition, that is muscular dystrophy, we told that figure. Again and again dying there like that. That is progressive condition. Then no progressive condition, I showed the second picture from the starting of the class, that is cerebral palsy, that non-progressive condition, that cerebral palsy. And fifth condition is this unborn child, or that is severe congenital malformations. So ultimately, different types are classified. For our management purpose, it can be divided into three. That is malignant oncological conditions, non-oncological condition with no specific diagnosis. That is why I told some genetic and rare diseases may not be able to get the diagnosis. That also is classified. So you have to broadly classify into three types: oncological, non-oncological, and those with no specific diagnosis. So you have to, this complexity, and you have to assess the complexity of the each child and the family needs. So each child will be unique. One child having leukemia may not having the same issue as the other child. So each child is unique. So you have to assess their individual needs, individual complexities we have to assess, the child and the family. So what all things we can do? We can do early identification. So recognizing the children who benefit from palliative care is essential. Then tailored care. The palliative care needs differ across these groups. So requiring specialized approaches to symptom management and support. The resource allocation. So understanding the trajectory of illness helps in planning and providing appropriate resources. So knowing the trajectory, we can plan. So early can identify the tailored care you can give, and resource allocation. We can plan how to plan. So we can do the symptom management, assess the family's goals of care. So day by day, the goals of care can change. Depending on the current status, what is our goal? How we can the goal, what we have planning, and we can discuss with them. So in repeated multiple settings, discussion in multiple settings needed, so that we can make a shared decision. So that we can help them take a decision. We can tell them the options. These are the options available. What all things we can do. So you have to sit with them and communicate with them so that they can make a decision making. Definitely, they may not be able to do the choice of treatment at all. We may be giving so many options. This, that, we can do that treatment, we can give like that. But they will be in a dilemma. There we have to be with them, sit with them and make them, empower them to take one option that is suitable for their child. Not our appropriate for us, should be appropriate for them. And advanced care plan. What is that advanced care plan? That means we have to counsel them what all things, you have to counsel them the prognosis. That is most important. Generally, what is being seen is in the conventional management, we will treat the current situation and manage and send them. We won't be counseling. We are not bothered about the prognosis, telling the prognosis, what all things happen. But in palliative care, what we are doing is we'll tell them the prognosis. This is the things that child can, what all complications child can develop. That is an important aspect of palliative care, advanced care plan. What all prognosis, what all complications child can develop. So what all things we can do at that time. All these things we will discuss and document and keep. And we needed care coordination. So multidisciplinary management. Child may require physiotherapy. Child may require speech therapy for this swallowing, feeding issues. So all these things you have to coordinate them. And ultimately child may require end of life care also, followed by bereavement support for the family. So the team, what is a team? Includes physicians, nurses, social workers, pharmacists, nutritionist, psychologist, physiotherapist, art and music therapist. Even the administrative support also is definitely needed. So we may not be having all this, but we have to make some coordination. Whatever support is available, we have to make use of it and coordinate with them. So relationship building and communication, that is the first part. That is, you are building a rapport with them. We are talking with them and we will assess their needs, their wishes and desires. Only when we are talking to them, when we are close to them, then only we will be telling their hidden issues. Otherwise, they won't open up. We have to explore the family's values and beliefs. So perception of their illness, what they're in their mind, what are their goals of care, so that we can guide them. So that relationship building and communication is the pillar of palliative care. So when we are in the communication, is the class over on communication? Communication. Can anybody tell the class on communication, is it over? Breaking bad news and all.
Yes, ma'am.
Over. Okay, okay. So participants are not responding. How many sessions? A single session or 2 sessions?
Are you asking to me or participants?
Participants.
Okay. The participants kindly respond.
In the chat also you can tell, so that I can be sure that we are together. We are in the same boat. Somebody can respond in the chat box. How many sessions were there? Communication. Single session. Oh, somebody has told. Yes, Shen has told that is single session. Okay. So in this you might have learned, isn't it? Spikes protocol. That is, spikes means what it is for. S stand for setting. That is proper setting is needed. You can't tell them in the middle of a busy ward or busy OP. We have to be in a quiet private place as far as possible. Then you have to ask their perception. That is P for perception. First, you have to ask what all things you know about the child's illness. What all things are told. What do you understand? That is the perception. Then you have to invite them. Are you, do you know? Then do you want to tell me the details? Then sometimes they may tell, if you're asking, sometimes the mother, she may tell, no, but let my child's father come, or let my parents come, like that. So you have to invite them also, include them also. Then they are in a position to know the condition, then we can tell the disease. But here also we have to be careful. You have to think in a understandable way, so that they can digest whatever things. You don't to be in a rush. Take sufficient time so that we can tell them in an understandable way. Definitely when we are selling the bad news, there will be emotional outbursts. They may be crying or getting angry, getting frustrated. So that also we have to handle. And then finally we have to begin with the conclusion, some strategies, what all things in the plan of follow-ups. So all these things includes the spikes protocol. So in the day-to-day practice, we can see, so that you will feel confident. If you are using the spikes protocol in your daily practice, you will be feeling confident and you can do your work in a better way. So what about this nurse mnemonic? What is that? That is nurse mnemonic for responding to emotions. Whenever there is emotional outburst occurring, this is protocol can be used. So identify the underlying emotion. Sometimes the father might start crying or outbursting. Then you can tell, okay, I sounds like, you can tell them, okay, it sounds like you are worried. Then what about then understanding? What is that? We have to tell them that we have understood that you are in such a situation. So that you have to tell. Then respect. Okay, it is okay to have these emotions, that you have to respect their emotions. And then you have to support. So we are here. Whatever possible, we will try to do. But all these are things like that, you have to support them and explore. So we may be asking, why will my child die? Like that, when you are, why you are told so that you can explore, so that we will continue what all things, what all the worries in their minds. So this is a mnemonic for like the spikes protocol for breaking bad news. For responding emotion, the nurse protocol, nurse for naming the emotion, understanding, you for understanding, respecting, supporting, and exploring. So this protocol in the day-to-day practice for whenever you are facing with some parents showing emotional outbursts, you can use this protocol. So the developmental stages. So we already told in the children, we have to consider them in a different way. Depending on the developmental age of the child, we have to manage. So we must have that competence to relate with the children according to their cognitive, their whatever development emotions, social and physical stages of development. We can't this approach to all the children in a similar way, depending on their development. We have to approach that tactics we have to learn. Also, transition procedures. Once a child is at the age of 18 years, they will be transferred to the adult department. That also, then also they will be facing so much difficulties. You should not do that at a sudden. That also we have to make. That is also, there also the role of palliative care is important. Smooth transition to the adult services. So these are the rapport and then the communication, then goals of care. We will be discussing with them. Goals of care already told. We have to make multiple sittings and sit with them to help them take the decision. So most of the times the child may already having serious disease and more complex symptoms. There it will be very difficult to assess also, but our approach should be to better, so that betterment of their quality. Somehow we want to increase the quality of their life. That is, there is not much high technology and all, there is human touch. That is increasing low technology. Don't want to do inverse investigations and all in such a futile management. We have to be with the humanity. The goals can shift. On the diseases progresses, the goals can day by day, the goals can shift. What is the goal of them in the first day of diagnosis? It won't change day by day. On the disease progresses, the goals can shift. So then you have to maintain, that is the importance of this longitudinal relation. When the child is actively dying, and when we are seeing for the first time at that time, they may not trust us. But if we are being with them from the initial stages and we have made a rapport with them, it will be very easy for us to make them convince the status of the child and to make the decision, help make the decision. So family should be the center. The child and the family should be the center. Not we are telling and they are following. Not like that. We have to make them understand. We have to empower them to face the situation and make them make the decision so that is in the best interest of the child. So we should try to understand the family's hopes, the medical condition and the family's experiences till now, the difficult journey they might already gone through, their culture, their beliefs, their lifestyle, and their community. All those things we have to take in consideration or determining the goals of care. There is no right. Whatever thing is right for one child may be wrong for the other child. So whatever thing is the best decision for the particular child, that we have to take. And then the advanced care planning, that already told, that determination of goals and preferences for future medical treatment. What all things the next day or the next month or next year, what all complications the child might develop and what all things that are the options. So what is a preferred place of end of care? And even that you have to. Definitely we can't discuss with this in the first sitting. Day by day, we will be multiple sittings. We will be discussing with them. Once we gain the trust and all, we can tell about this include also. So family-centered care, that is our ultimate aim. So you have to respect them as the partners in care. And the care plan should be discussed openly and honestly. And the support should be provided for the family decision making. That is, flexibility is care is important. Whatever we are planning in today may not be feasible the next day. So the family involvement that will help in the adherence to the treatment. So shared decision making, definitely when you are taking shared decision making, you have to follow the 4 basic ethical principles. That is autonomy. They should have the freedom to take the choice. And also maleficence. Whatever things we are doing, that is in the best interest of the child and do not do any harm. And the judgment, that is, we have to follow all the 4 basic ethical principles. So supporting families through their emotional, financial, and practical challenges. Definitely when they may have been financial crisis. So we can connect them with some services available, or we can tell the options. You can help with them with the options, giving them with so that their financial crisis won't aggravate. So counseling, connecting to social services, and financial guidance we can give them. So family-centered care ensures they are part of the decision making. Then respite care, what is that? Respite care. This already I told that first figure that picture, second picture I told that the child is already 12 years. For the last 12 years, the mother alone is taking care of that child. She might have burned out, isn't it? So that part also we have to taken care of. She may need needing some rest. That is respite care. They may be admitted to some facilities wherever available, wherever hospice settings or some palliative care centers are there. They get admitted for a few days, or someone is other help for her, so that someone will take care and she can take some rest. That is, respite care is needed so that it will reduce the caregiver burnout. They have to educate them, the families, some manage the symptoms. We are planning the advanced care plan, and if we are teaching them the simple things, how to do suction, how to do injection, how to do subcutaneous, how to give suppositories. If we are educating them, they can manage the simple things at home. Otherwise, unnecessarily, they have to take their sick child to the faraway hospital in every day. So, spiritual support, that also is needed. That is also crucial during the illness. So care we have to coordinate with the multidisciplinary care of doctors, nurses, psychologists, social worker, and therapists. So palliative care providers optimize the communication, and the social workers or nurse coordinators can connect the family with the community resources or services, and also we can connect to the support groups. There are many parent support groups, and we can connect them with them so that they may help each other. And also we can connect with the volunteers. Volunteers are there in the palliative care field. We can connect with them so that they can do well. Then the symptom assessment, I told the difference is there. Among children, it is difficult to assess the pain. So you might have learned the pain class is over, I think. So how will you assess the pain in an adult? Which scale you will use? Can anybody tell or chat? How will you assess pain? No response. Is the pain session over? Pain class over? Pain assessment, management of pain.
Yes, ma'am.
Then let the participants tell or chat. How will you assess pain for a person with complaining of pain, an adult person? Yeah, Kanagaraj had told it correctly. That is numerical rating scale, isn't it? We'll ask the person how that on a scale of 0 to 10, where is your pain? There some person may telling 4, some may tell 6, some may 8. But in children, how will you assess? They won't be responding. In infants and toddlers, it is difficult. Newborns, they are also having pain. In fact, they will be experiencing pain even from the intrauterine period. And the inhibitory mechanism is not developed. They are facing more pain compared to adults. But we are in a position, difficult to assess it. So many scales are there. Premature infant pain profile, newborn infant pain, cry, so many options are there. In above 4 years, they can self-report them. Above 4 years, in pre-KG and all, there will be that age group. They can self-report the pain. This is that phases shown. That is phases pain scale revised. FPS, phases pain scale. So how will you use this? We will be showing this chart. Note that we are looking at the child's face and assuming that child is having, not like that. This you have to show this chart. This chart is freely available. You can download and keep, so that when you are assessing the vitals, you will be routine work. You will be assessing the vitals, isn't it? Pulse, respiratory rate, like that. So pain is considered as the fifth vital in the palliative care. Then it's the fifth vital. So in the routine life, you can assess the pain. You have to ask the child to point to the face where you experience your pain is, like that. The child is, suppose the child is in the last figure, that is having the child's having the worst pain. Suppose one child is pointing to the first figure, means that child is having no pain, like that we can use. Another one is the finger span. Child can show with the finger that how much pain, this much pain, very much pain, like that. These are the different techniques to assess pain in children. The infants, another one is FLAC scale, that is FLACC, that is face, legs, activity, cry, consolability. That like that pain scoring is also available if it is more than 3. The score is coming, total score is coming more than 3, that is among 2 months to 7-year-old child. That also indicates pain. Another option is body maps. Above 5-year-old child who is able to color and all, they can color it over this face. Wherever there is maximum pain, they can label it as red, like that. Green means least pain, and red, like that. This different color coding they can use, so that we can know the intensity also. So definitely, as you told, that is visual analog scale above 8 years. Only above 8 years only we can use this visual analog scale or numerical rating. Then when the number is put, it is taken as considered as numeric. That is numerical rating. Here the scale is without any numbers, isn't it? The final one, the last one, the numbers also written, so that we can get the accurate picture where the pain is. So numerical rating scale, and it is a WHO ladder. What is the difference from the adult ladder? Is there any difference? Can anyone point out that difference from the WHO pain ladder for adults? What is the difference? Can anyone tell in the chat, or can you tell? It's a non-difference. Participants? Any difference? Are you? Here, what is shown is only 2 step, isn't it? In the adults, when we are seeing it, there is a 3 step. Here only 2 step. That is only step 1 and step 2. That step 1 means what is that? Mild pain, and step 2 is moderate to severe pain. So the mild pain, what all things you can give? Paracetamol. And these are the drugs. Pain and symptom management, the pain management for children. What all things we will be using? The mild pain, we will be using paracetamol or NSAIDs, or paracetamol and NSAIDs. And among the NSAID, the most commonly used one is ibuprofen. Paracetamol and ibuprofen. The severe pain, strong. There is no role of weak opioids. That is the main difference in the treatment of pain in children. We are not using weak opioids because it is not, that research evidence is not there, and also the reports of serious not effectiveness and also the reports of adverse effects. That is why weak opioids like codeine and tramadol are not preferred, advised in children, not recommended in children. There is child having severe pain, moderate to severe pain, straight away go to strong opioids like morphine, methadone, like that. Fentanyl, those things we can use. Only thing is these weak opioids like codeine and tramadol, not recommended. And the titration is based on the pain severity and the patient response. And also adjuvants we can consider for neuropathic pain and all, we will be giving gabapentin, amitriptyline, etc. So adjuvants we can go for. Only thing is that weak opioids are not preferred. Definitely there is role of non-pharmacological. In the children, you might be in the pediatric practice, routine practice for immunization, injection purposes and all, we'll be using distraction techniques. You'll distract them by showing some pictures or some singing some song or some making some music, making them hear some music. Then heat or cold packs for pain. And the important point is that you should regularly assess the pain. Sometimes when the child is crying, they will be crying of pain, but we will be thinking that the child is crying because of fear, but actually they are suffering from pain. So also you have to caregiver, we should educate them on the safe dosing, also the possible side effects. So the regular follow-up ensures adequate pain control. So psychological care, this emotional support to the cope with the illness. Here the psychologists and counselors play an important role. We have to counsel not only the parents, they have to counsel the children, that patient or that child also, and the other family members. So you are connecting the support groups, they will get a very much relief. So that also school, you have to tie up with the school and this teachers and have to make some adjustment, some benefits so that the child will get help from them. There are also art and different options like art and play therapy wherever feasible, we can tell them to, we have to coordinate with that also. Then the spiritual care, that is you have to respect the cultural and religious beliefs. We may involve the spiritual leaders so that they will be relieved. The spiritual support can provide hope and discomfort. Can help families find meaning in their experience. Also this end of life rituals, that also, that is whatever that is their belief, that should be respected. Social support for the whole family and identify the financial needs, develop social support networks, referral to the NGOs available and support for the legal requirements. For especially for children with disability, we have to help them getting the disability certification and all. We can connect to them so that they will be taking the Aadhaar card, the disability assessment. If the benchmark disability more than 40%, they will be getting the disability certificate and they can get so many benefits. So that we can connect them to the available government schemes for different diseases. The schemes are there. Whatever schemes are there in our setting, we can connect with them. Finally, the hospice and end of life care. It is care of, what is this end of life care? That is care of the child who is actively dying. It also includes all the components, that is total suffering, physical, psychological, social, spiritual. It even includes the bereavement support. What is this hospice? What is the difference? That is hospice means the palliative care that focuses on comfort. Generally in the outside countries it is available, especially for those who are less than 6 months to live. Their hospice nurses are there, social workers, chaplains, child life specialists want 24/7 access to healthcare provider. Medications for comfort will be given, equipment, medical equipment, sometimes the BiPAP and oxygen concentrator may be needed, pulse oximetry, and also they include legacy building activities, memory making. So legacy building actions or behaviors means what? It is aimed at being remembered. And can say maybe some photographs, some videos, some hair locks will be like footprints, some photos, all those things we can. So it will improve the coping and adjustment during illness and end of life for patients and their families. So the effort to create memories and confirm they are loved and it will be remembered are important. So the children, they are also having not only like the adults, the children also might be having so many wishes. So once they know they are going to die, they will be delegating so many things. I have seen so many children telling, give these books to those of my siblings, these toys to that sibling, like that. That also is there. We have to respect their wishes also. They will be delegating their certain belongings after their death. So maybe writing letters, drawing pictures. They need a special trip. Possible, we have to make sure that it is fulfilled. Or they maybe want to see some familiar figures, their popular figure, their some relatives. So that also wish, whatever wishes we can do, we have to make fulfill their wish. So nowadays there is in other countries there is animal assisted intervention is are being done. That is those with child with serious illness. If those children who like pets, cat, dog like that, that also is having the research source that also having very much effect on the improve the quality of life. So end of life care, that is all the evolution you have to discuss with them. So the wishes of the child and the family and the available resources. So the all the symptoms should be managed so that they can die with dignity. So you have to make them calm and so not be in a panic, so that in the prior discussion is there means they will be prepared. Family will be prepared with the dying process. So we have seen that child, first we told 10-year-old child with osteosarcoma. What all things we can do for that child? Not only giving the paracetamol, what all things we can do? We can connect. If the palliative care services are there, we can connect the other members, isn't it? For psychologist, social worker. Because the palliative amputation may be carried out once they are giving consent. You can give can share decision by decision making. So we can all these team members can take part in the active role. No physician, nurse, psychologist support. Once if it is over means then they may need help of a physiotherapist. They can walk with the prosthetic limb. So whatever possible that help also we can coordinate. So the ultimate thing is, it is the model, the current model, that is biopsychosocial model, that is multimodal approach. We have to approach all the aspect, that is total suffering will be taken care of. Not only the physical symptoms. So who is this lady? Anybody knows who is this lady? Participants, if anybody knows, you can put in the chat box. Please. It's a prominent figure in Dame Cicely Saunders, that is founder of St. Christopher's First Hospice, that is St. Christopher's Hospice. So she is a prominent figure in palliative care, especially towards this pediatric palliative care. So what he is telling is, go around and see what is being done, and then see how your own circumstances can produce another version. There is need for diversity in this field. So palliative care means it is for the different or the each child you may have to do some different things depending on that particular child, unique to that particular child. So with this, I hope you have understood the basics of pediatric palliative care, and let me stop the session. So if you have someone having any doubts or discussion or comments, you can tell, we can discuss.
Dear participants, kindly ask your doubts.
Or you can chat in the box if any your comments, any your experiences, or we'll discuss. So one person was there and working in pediatric Kanagaraj, isn't it?
Madam.
Yeah. Where are you working?
I'm working in Raipur, madam. Not in pediatric palliative care, madam.
In pediatric palliative care. Okay. So you may be having so much experience now. You can share which all cases are commonly you are seeing?
No, madam. As a in charge, I'm working, madam.
Yeah. Pardon?
As a supervisor, I'm working, madam.
Okay. In charge.
Deep
Okay.
depth knowledge, I don't know, madam.
Not into the clinical practice. You are in.
Yeah, madam.
Okay.
Supervisor post, madam.
Okay. So, but you can do great things now. You can coordinate with them. What all
Yes,
services is
madam.
available? That all things you can. So, anybody will Sonam? What about Sonam? Sonam has commented many things. Is Sonam there? Not there.
Sarita Sharma? We have only 2 more sessions, so if you have any doubts regarding pediatric palliative care, please ask. So if you are dealing with children, it's little bit sensitive. So please follow the rules and everything that ma'am had told. So ma'am, I think we can wind up for today.
No doubt.
Yeah.
I hope everyone has understood the basics so that you will be practicing it in your
Yeah,
over.
true, ma'am. Most of them are not even responding. So we can just call their name, that's it. So thank you, ma'am. Thank you for the insightful session. It was very helpful. I think Mr. Kanagaraj was attending the session properly. Yeah. Okay. So thank you. Thank you, ma'am. Thank you, participants, for attending the session. And we have 2 more sessions. Okay, ma'am. We can wrap it up for today.
Okay, thank you.
Yeah. Ma'am, is this the same PPT that
Right, yeah, same one only.
okay.
You are from working in?
I'm from Kerala, but I'm working at Sparsh Hospice in Hyderabad.
Right, okay. There only this IAPC conference is planning, isn't it?
Yes, ma'am.
Okay.
Next year.
Okay.
Are you coming?
I'm planning.
Okay. See you then, ma'am. Yeah.
Okay, bye.
Okay.